Then the inspection for the feet and ankle, it's important to look for the foot structure, looking for flat feet or looking for high arch feet, such as pes planus or pes cavus. Then you want to examine the patient from behind to see if there's good calcaneal movement. And to do that, you have the patient stand about shoulder width apart, and then you ask them to step on their toes, and you're looking for varus movement of the calcaneus. Come back down, and then do that again. And as this patient steps on his toes, you can see that the calcaneus inverts, and that is normal motion. You can come back down. If someone who has pes planus, such as our patient has, you want to make sure that that is flexible, and the way to do that is to look for good heel motion. In addition, you want to look when you're behind, looking for what's called the too many toes sign, and that would be from behind, seeing that you see the fourth and fifth toes from the outside, and that can be a sign of posterior tibial dysfunction. This patient does not have that. This patient does have pes planus, and so it would be important to ensure that that is a flexible flat foot, and the way to do that is to have the patient step up on his toes. And here you see our patient's calcaneus internally rotates or varusly comes on in, come back down. The next portion of our exam will be the palpation. Remember, it's a purposeful palpation where you're trying to elicit structures, looking for their integrity and looking for any pain. On the ankle, it does not matter if you start the medial or the lateral portion as long as you go systematic, knowing that you have to examine the lateral, the anterior, the medial, the posterior, and the plantar aspect. For demonstration purposes, we'll start on the lateral aspect. Normally, you'll examine the asymptomatic side, moving to the symptomatic side. On the lateral aspect, you're specifically looking for tenderness at the lateral malleolus. Then you're also looking for any tenderness at the anterior inferior tib-fib ligament, or for syndesmosis sprain, which runs here. The lateral ankle sprain most likely is the anterior talofibular ligament, which runs from the fibula to the talus. This is a vague area. You will not feel a discrete structure, but you're looking for tenderness there. Then there's the calcaneal fibular ligament, which again is not a discrete structure. You're looking for any tenderness. You have the perineal tendons or the fibularis tendons, the longus and brevis, which runs behind the fibula, whereas the brevis inserting on the base of the fifth metatarsal and the longus going underneath the foot, and you're looking for any tenderness in that area. You will then palpate the base of the fifth metatarsal. You will then move to the medial structures, knowing that you're going to try and palpate the whole length of the metatarsals down to the metatarsal heads as the patient's complaint dictates. The midfoot area, the Lisfranc complex, is in this general area. Then you want to palpate the navicular bone. The way to find the navicular bone is ask the patient to dorsiflex. There's the extensor hallucis longus tendon and the anterior tibialis tendon, and right in between those two tendons is the navicular bone, and you're palpating for any tenderness there or on the medial aspect. For demonstration purposes, moving on over to the medial aspect, you'll palpate the medial malleolus, with the deltoid ligament being a broad ligament that you cannot discretely feel, but you're palpating the medial malleolus. Then on the posterior aspect, you're looking for the Achilles tendon all the way down to its insertion of the calcaneus. Then you'll palpate the calcaneus itself for any tenderness. Finally, on the plantar aspect, you're palpating the medial tubercle of the calcaneus where the plantar fascia originates. You can put that on stretch, and again, looking for any tenderness, and you can feel that structure there. And then you'll feel for the sesamoid bones, for which there are two. There's the tibial sesamoid and the fibula sesamoid. That would complete the palpation portion of your exam. After you've done palpation, you will move on to range of motion. For range of motion, you would ask the patient to dorsiflex both their feet. You would ask them to plantarflex both their feet. And then you can try inversion, and you could try eversion. And that would complete your range of motion testing. To test strength, you simply would just resist those motions, inversion, and then eversion. That would complete the inspection, the palpation, the range of motion, and the strength testing. Then you would move on to special tests. The majority of our special tests are built around testing for any ankle sprains, and so those are usually done more in the chronic setting, but we'll demonstrate them at this time. So the first test we do is the anterior drawer, looking for the integrity of the anterior talofibular ligament. This has been described multiple ways in the literature, but what we would like you to do is having the foot in plantar flexion, you stabilize the tib fib, and you're simply pulling on the ankle, seeing if there's increased translation. You can do it by cupping the ankle or by pulling the ankle, but again, you're stabilizing the tib fib, pulling the ankle, and you want to compare side to side. Next, you want to test the integrity of the calcaneofibrillar ligament, and that is done with a Taylor tilt test. You can either do that in plantar flexion, where you can compare both sides, or you can do that in neutral, where now you're going to stabilize the tib fib and you're going to invert the ankle, again looking for any increased translation, comparing side to side. And that was our test for our lateral ankle sprain. Next, you want to ensure that they do not have a syndesmosis or a high ankle sprain with disruption of the anterior inferior tib fib ligament. And there are two tests that we do for that are the squeeze test. In the squeeze test, you are actually trying to compress the tibia and fibula. And if there is pain or disruption of the syndesmosis, it will open up. So as you squeeze the tib fib, the patient will complain of pain. Then you will do what's called an external rotation test. You put the ankle in neutral, and you externally rotate, and you're trying to force the fibula open. And if there is an injury to this tib fib ligament, there will be increased movement, and this will cause pain. So the squeeze test, and then the external rotation test. Next, you want to test for the integrity of the Achilles tendon to rule out Achilles tendon rupture. That's called a Thompson test. It can be done in a variety of ways. The concept is if I squeeze the calf muscle, there's a little bit of plantar flexion there. If you have good movement with them in the sitting position, that would suffice. Or you would ask the patient to roll over on their stomach. Go ahead and roll over on your stomach for me, please. And as I squeeze his calf, you can see that there is plantar flexion as I squeeze the calf because the Achilles tendon has integrity here. This would actually be called a negative test, whereas a positive test would mean there's no movement when I squeeze the calf. And that is called a Thompson test for the integrity of the Achilles tendon. You can go ahead and sit on up for me. We would do a Tinel's test looking for the tibial nerve behind the medial malleolus, remembering the structures behind the medial malleolus have a clever mnemonic, Tom, Dick, and a very nervous Harry, where the T stands for the posterior tibialis tendon, the D stands for the flexor digitorum longus, the A stands for the artery, the V stands for the vein, the N stands for the tibial nerve, and the H stands for the flexor hallucis longus. So knowing that the tibial nerve runs behind the medial malleolus, you're looking for tarsal tunnel syndrome, and you simply would perform a Tinel's test by tapping on the tibial nerve, looking for reproduction of the patient's symptoms. That would complete the ankle-foot exam.